Well, good morning. We will go ahead and get started. Happy Saturday to everyone who is joining us this morning, and welcome to the 22nd annual Blazing Toward a Cure. Certainly in a different format this year, but the spirit is the same. We are all excited to be with you all today, and even more excited to be virtual given the weather outside here in Middle Tennessee. So thanks for all of you who are logging in. Just a friendly reminder that all of the presentations by our presenters today are available via YouTube. They will live on the YouTube link following our chat today, so we welcome you to consider viewing them at your own leisure if you haven't already, or to continue to revisit them for the wonderful information that they have been able to share with us. And also a reminder on how we thus far have been collecting questions. We've encouraged folks to send in questions via email and calls to Kelly, and she is Kelly Arney, as you all lovingly know her from the Parkinson's Foundation Center of Excellence team at the Vanderbilt. And she has prepared those questions and made sure that each of our presenters today have your questions and are ready to answer. She will continue to facilitate those to our presenters today, and we'll hopefully get through as many of those as possible. In addition to that, we are collecting questions through the Q&A button, which you can locate at the bottom of your Zoom screen. So if you'll go ahead and take a quick pass, there's a Q&A box there. We will be encouraging you throughout the questions today to continue to submit your questions. If time allows, we will get to as many of those as well as possible. So without further ado, Kelly, I turn it over to you, and thank you in advance for all your coordination, and looking forward to hearing from each of the presenters today.
Thanks, Amanda, and good morning, everyone. It took a team to present this, so I want to thank all of our presenters who got their talks loaded on YouTube early. And I've got the questions, and we're going to start with our nurse practitioner, Steve Afrow. I'll ask him a few questions that were submitted early, and then we'll rotate that way. But as Amanda said, feel free to submit questions. If whether you've watched the videos or not, please submit your questions. So Steve, as a care partner, I'd like to attend the appointment, but my wife doesn't want me to. How should I handle this?
That's actually a really good question. I get a lot of people ask me that as well via messaging. I think the big thing to remember, this is more talking to the patient specifically, but the big thing to remember is that we're kind of all a team in this. You know, Parkinson's is a disease that is successfully treated as a team. That is the doctor, myself, the physical therapist, the patient, and the caregivers. And there's a lot of valuable information that he or she can give. And by coming to the appointment alone, there's a lot of things that I think could be missed, whether it's things you just honestly don't realize are happening, or things you are kind of afraid to tell us they're happening. So the better we get, or the better picture we get, the better understanding we get from everyone who lives with you, it helps. And if you just think of it this way, I mean, we see you as the patient, we see you for what, 30 minutes every couple months. Your caregiver, spouse, friend, whoever it is, sees you almost 24/7. So they have a lot better understanding of how you're doing, both the good and the bad. And it's really helpful for us in terms of treating you, you know, for everyone to be there and everyone to participate.
Thank you, Steve. The next question is, before my appointment, how can I do a better job of tracking symptom variability? How detailed do I need to be when reporting to my doctor or nurse practitioner?
Also a very good question. What we do, and I believe Kelly has kind of a form we can share with people that kind of gives them a little bit of a diary thing where they can follow along and kind of answer some questions that help them get themselves organized. But I think the biggest thing we're looking for is kind of two parts. Is number one, we want details of trends and patterns. We want to see how you're doing with symptoms over time, not necessarily in one particular day. And we can do that in many ways. You can do that by writing stuff down. You can do that by taking videos of symptoms. So there's a lot of different things you can do that kind of can relay the message to us. But really what we want is just patterns and trends. You know, if you're having trouble sleeping, for example, we want to know how your sleeping has been over 30 days versus just 1 or 2 days. So we really want to see things over time. So you don't have to give us every single detail of every single day, but just be able to say, yeah, half the week I struggle with this, and I notice that it's days when I don't exercise or whatever it may be. So patterns, trends over time, that's kind of really what's going to help us more than anything.
So this one you've kind of already alluded to, but is there an outline that can help us prepare for the appointment that we can work on together?
Yeah, and I think the outline is going to change a little bit from person to person, but really what you want to do is make a list, and you want to prioritize that list, and you want to say, what are my top 3 issues that we want to work on today? Write down some details that you can talk about from those issues. You want to write down when they happen, how they happen, what triggers them, what makes them better, and bring those to us. And I think that helps you stay organized by focusing on really just 1 or 2 or 3 things versus kind of worrying about every kind of little symptom that you have, whether it's a small one that pops up every once in a while or something that happens every day. But just really making sure that, you have your thoughts organized and written down, but it's going to change from person to person. It's not going to be a universal outline for everyone.
I feel like the doctor doesn't get the full picture. How do I let the doctor know my opinion as the caregiver without interrupting the appointment?
I think that was actually one of my favorite questions. And what I would say too, I would reword that question is to say, I think the word interrupting is a bad word. You're the star of the show. You're the rock star. That's what I tell my patients is you're the boss. I'm just here to kind of guide you through this and give you advice. At the end of the day, it's up to you what we do and what we don't do. So what I always tell people is when you walk in, the first thing you really should be talking about is, what's on your mind. Bring your list, bring your videos, whatever you did to organize yourself. And at least when I start my visits, I'll always tell people, okay, I see you brought a list with you. Let's start with you. You start talking, kind of run down your list. I'll make some notes. We'll prioritize what we want to talk about. And then we'll go down the rest of the road and talk about everything else. But I think the biggest thing is when you come in prepared and kind of know what's on your minds, it kind of helps us lead the direction of the visit. But you're in charge, you're running the visit. Don't forget that. And if people tell you otherwise, that's speak up. Don't be afraid to speak up if that happens.
Thanks. The last question is, my symptoms seem to be better at the appointment than at home. Why is that? Should I skip my meds that morning so the doctor can see the symptoms more clearly?
That is also a wonderful question, which I do see a lot. I would say no, don't technically leave off your medicines unless we tell you to. There are certain circumstances where I would tell someone to do that, but most of the time I wouldn't. The reason why that happens, kind of what I tell people to simplify it, is the Parkinson's brain is very bad at multitasking. So if you are focusing on what I'm telling you, if you're focusing on walking down the hallway, if you're focusing on one specific thing, if you're kind of pinpointed on one specific thing, it's going to be a little easier to control it. So if we're talking about your tremors and you're looking down and I'm seeing patients just staring at their hands, they can control the tremors fairly well. If I have them start walking up and down the hall and doing jumping jacks, whatever they're doing, the tremor can come out more. So there's kind of little tricks we do to kind of see how things work. So I would say don't necessarily skip your medicine, but that's kind of the science behind it is when you're out in public and you're doing things and you're distracted, you might not notice the tremor as much, or for example, or you might not see it as much, but when you're in with us, you're hyper focused on those symptoms. So it's okay. And what I always remind people, going back to the video comment I made, is if you have a symptom that's bothering you and you just have the terrible luck that it never pops up when you're with us, get a video of it. Show me what it looks like on video, and that's going to give me a lot of information so I can help treat it.
Thanks, Steve, on those answers, and we're going to move on to our next presenter, Dr. Amy Brown, and her presentation was the COVID impact on mood. The first question I have for Dr. Brown: when referring to shorter periods of depression and longer periods of depression in Parkinson's disease, are you referring to rapid cycling, and what would differentiate the two?
So I'm not referring to rapid cycling when I was talking about how in Parkinson's disease, there's shorter periods of depression. And what I meant by that is, when we classify depression psychiatrically, it's a major depressive episode. And that tends to be a 2-week period of being persistently down and not interested in self, which we tend not to always see in our Parkinson's patients. Our Parkinson's patients tend to have maybe more short time periods of being depressed or feeling down. And that's kind of the symptoms we want to make sure we treat, because, if you're feeling down sometimes and you just don't have the energy to go out and get exercise, do the things you want to do, I'd rather treat that than wait for you to feel persistently down for 2 weeks, Rapid cycling is actually a term for bipolar patients. And that's actually a term, it means something different. It means that you're having about 4 episodes in a 12-month period of mania, hypomania, and depression. And mania is actually like euphoria, increased energy, decreased sleep, racing thoughts, things, maybe that are just a little bit different than being depressed. It's a little bit more hyperactive, basically. And so it's a different type of condition than I was just discussing. I don't have anything to add after that. So.
We lost you for a second, but the next question is, what about CBD oil for my mood? Is it safe?
So I frequently get asked about CBD, and it's, it is hard to really adequately discuss it with my patients. There was a great JAMA article, so the Journal of American Medical Association, from November of 2019, that I usually try to reference when I talk to my patients. And one, it discussed how there's really limited evidence, particularly when it comes to depression. They are trying to start studying in mood, but there's just insufficient evidence that it's working. The only actual treatment that is FDA approved with CBD oil is a medication called Epidiolex, and that's for a seizure disorder, very rare seizure disorders in children. And in those studies, they saw that, patients had some GI upset, meaning nausea, just not, not feeling well in the stomach, some sedation. And there was some concern that there may be some liver damage long-term that they're still studying, is my understanding. When it comes to other, other evidence out there, it's just very limited. And additionally, since it's not FDA approved and it's just being out there made by whoever, there's a lot of evidence, or there was a study that looked at 20 different CBD oils out in California, and they found only 3 of them actually had the amount of CBD that they said they did. The rest had more or less, and 2 of them, I believe, had no CBD at all. So it's just kind of like, you don't really know the quality of the product you're getting because it's not regulated yet. So it does make it challenging to say, to take it. I think most of the evidence says it's relatively safe. They're still studying how it interacts with other drugs. But you also just don't really know what you're getting, particularly if you're getting it from like a gas station or something. It's hard to trust something from there. And also I get really worried about the cost of it. I frequently have people tell me that they spent a lot. So I just find it really, there's limited evidence. It can be very costly, and, we have better treatments out there. But, I always tell patients, if they want to try it, go for it. But you can always come back and we can try something else too.
Thank you. The next question is, COVID has affected my mood, but everyone is having a hard time. How do I know if I should try a medication? I'm not enjoying things, but there's not a lot to do out there anyway.
Yeah. So I agree. Everyone is struggling with COVID. We're all kind of more homebound. And so I think really, on a personal note, I'm trying to find like enjoyment in the little things I can. I guess I was always a little bit of a homebody, but it's been even harder now. But I think if you're really not enjoying even those little things that you can do, I would come and talk to your physician and consider starting a medication, because it's, life is only so, it's so short, and why spend some time of it even not enjoying, even though we're in a pandemic, you don't have to not be enjoying life still.
Thank you. The next question is, antidepressant medications were mentioned around mood in your talk. Mm-hmm. Do they have withdrawal symptoms if stopped? Maybe because I didn't feel like they were effective, and if so, which ones have the least withdrawal symptoms?
So, I think every medication has side effects, and I do think most antidepressants have a risk of withdrawal effects. I was trying to think of one that didn't, and I couldn't offhand. But when I start a medication, so first, when you start an antidepressant, it usually takes about 4 to 6 weeks to even notice a therapeutic benefit for most of the antidepressants out there. So, and then that's only a therapeutic benefit once you get to the actual dose that's effective. So it usually is a ramping up period to figure out the right dose, depending on, the type of antidepressant we're using. if, you know, a patient wants to stop it, what I usually say is, you know, let us know, because some of them do have pretty significant withdrawal effects where you feel really uncomfortable, start having racing thoughts, maybe feel more depressed or down, or, you know, sweaty, or, you know, any weird type of symptom. So usually what I do is I will slowly taper the medication based off, you know, evidence on how to stop these medications. And that way, most of my patients say that they're able to stop without feeling any withdrawal effects. One of the ones, you know, for anxiety that's out there a lot is like benzodiazepines, which include like Xanax and Ativan, which some of you might be on also for sleep reasons. Those can have, you know, if you're on them for a long time, they do have a little bit more of an addiction potential, and they do take a longer time period for withdrawing, but I am able to get patients off those medications if they want to stop.
Thanks. How do I know if I should go to a psychiatrist for my mood problems?
So, you know, you can always talk to your physician first, whether it's a neurologist or your primary physician, and see, you know, what treatments you have sought already. A lot of times people start with psychologists. They're a little bit more accessible, or therapists in general, just to talk. Psychiatrists tend to, you know, there seems to be even more of a shortage of them than neurologists. And so they tend to take a while to get into. But they're really great, you know, for if you're on a number of medications, to help with managing all those medications, as well as they know a ton of therapies out there that even I don't realize. So if the, you know, the starting stuff isn't working, the initial medications aren't working, and we really need to seek more advanced help, a psychiatrist is really helpful then.
So finally, this is a little bit of a broad one, but what mood issues would you expect to see in Parkinson's disease?
So the most common ones tend to be depression and anxiety. Those are the most common mood disorders, which is why I discussed it. You know, as patients advance, they tend to have a little bit more psychosis, meaning hallucinations, or delirium, where they focus, or not delirium, delusions, where they focus on, like, you know, my spouse is cheating on me, or everyone's trying to steal my money. Some patients will develop delirium with time. There is also risk for impulse control disorders, particularly, you know, either from the Parkinson's or the medications itself, which means you go out on shopping sprees, gambling sprees, you know, and so those are things we'd want to be made aware of. And some patients also have personality change with time, or from the, you know, medications or deep brain stimulation. So there's, you know, a number that we try to address in our visit.
Okay, thank you, Dr. Brown. And we're going to move on to sleep issues in Parkinson's. And Dr. Kelly Brown is going to answer these questions. The first question I have is, even under the best of conditions, I barely manage 6 hours of sleep per night. I'm taking 20 to 30-minute cat naps in attempt to get more sleep. Is cat nap sleep classified as light sleep or deep sleep? Is it beneficial in giving the body more time to repair itself? And my general practitioner suggested taking trazodone, which gave mixed results. Any thoughts or recommendations on a path forward?
Yeah, hi, I'm Kelly Brown. So basically, cat naps are considered light sleep usually because if it's a short nap under 30 minutes, it's unlikely to get into the deep stages of sleep. The other important thing is that if you take cat naps throughout the day, it's going to be very hard to sleep at night. So normally what we tell people that are having a difficult time sleeping at night is to eliminate naps altogether, or to not take more than maybe a 30-minute nap during the day, because what you're really doing is worsening the problem or prolonging the problem by doing the cat naps. As far as the medication trazodone, it's really up to your treating physician to recommend a particular medication. We do worry a little bit about that medication sometimes in people with Parkinson's disease because it can cause some issues with dropping of the blood pressure and sometimes dizziness. So if you're already prone to that, it might make those symptoms worse. Again, I'm not going to, suggest a particular medication for anyone, but you could talk to your prescribing doctor about melatonin. That's the thing we probably recommend most often, and that's usually a dose somewhere between 3 and 10 milligrams.
Thank you. The next question is it dangerous to get too little REM sleep or too much deep sleep?
So usually your body gets about 50% of the night spent in deep sleep, such as REM sleep or what we call stage 3 sleep. It would be unusual for your body to get too much deep sleep. You only get really as much as you would need. And we do worry a little bit if you have too little deep sleep, but it's usually because of another cause that's preventing you from getting into deep sleep. So if you feel like you're maybe not getting deep sleep, it's a good idea to talk to your doctor, or maybe have a referral to a sleep center, or maybe have a sleep test, because it could be that you have sleep apnea or restless leg or leg kicking in the night or some other cause of poor sleep that's disrupting your sleep and not letting you get into the deep sleep. Deep sleep is restorative for your brain, so we think that people should have deep sleep, but there's no way to give it to you other than to take away anything that might be preventing you from getting into deep sleep.
Thank you. The next question is Seroquel used for sleep, and if so, what is considered excessive for Parkinson's disease?
So again, I wouldn't recommend a particular dose of medication in this forum. I think it's really important to talk to your doctor, because every individual patient might need a different dose. It is used for sleep in Parkinson's patients, particularly if they have other issues at night, sometimes behavioral or hallucinations or some more psychiatric symptoms, but it is felt to be safe in the right setting for the right person in Parkinson's disease.
Thank you. The next question is about restless leg syndrome. It wakes me at night and is tormenting. I'm on several medications, and I've tried several for the restless leg. Most of them leave me groggy the next day. Is this a part of Parkinson's, and do you have any suggestions?
Yes, restless legs can be very disruptive to sleep and very uncomfortable. One thing that a lot of people don't realize is that low iron levels in the body can contribute significantly to restless leg. So any patient that has restless leg symptoms should have their iron levels checked. If their ferritin, which is your total body store of iron, is under 75, getting that lab above 75 can be very helpful. And that's usually done through iron supplementation or increasing the iron in your diet, because some people develop constipation with iron. But it's also very important to know that if your iron is low, there may be a medical reason why, and you need to see your primary care doctor to make sure that nothing is being missed. Restless leg, a lot of patients with Parkinson's disease complain about restless leg symptoms, but some of the same medications used for Parkinson's disease also can be used for restless leg. So there is an overlap there. Another thing that can worsen restless leg is untreated obstructive sleep apnea. So again, it might be worthwhile to have a sleep test to see how much you're kicking at night, or whether you have sleep apnea, because treating that can significantly help the restless leg symptoms. There are also medications like antidepressants, which can aggravate restless legs, but a lot of people need to be on those for other reasons, so we wouldn't stop those per se just for restless leg.
Thank you. The last question is, you mentioned a worry time in your talk, and using that during the day. Is there a process for this, and how can it be practical?
Yeah, so a lot of people think that sounds kind of silly, but believe it or not, there's some evidence that that's helpful. So what you do is every day you set a time that you're going to decide that that's your time to worry, and you can sit and think about all the worries that you have, maybe for 30 minutes, whatever you feel is appropriate. Then later on at night, when you're trying to sleep, if you start to worry about all those things, just tell yourself, okay, I'm not going to worry about that right now. I'm going to worry about that tomorrow in my worry time, and try to clear those thoughts from your mind and think about something else. If you think I'm worried that I'm going to forget what I need to worry about tomorrow, you can actually have a small notebook by your bed and just jot that down. And sometimes just jotting it down and putting it out of your mind can be very helpful.
Thank you. Now we're going to move on to Dr. Phibbs. Dr. Phibbs did the talk on fatigue in COVID and Parkinson's. And the first question we have for you is, when I'm sick, my Parkinson's symptoms get worse. I'm afraid COVID would be even worse. Am I being too cautious?
That's actually a very common thing that we see is anytime your body has to put its energy to fixing something else, it kind of leaves your symptoms from other disorders that you have from a chronic standpoint unchecked. So anybody that has kind of chronic disorders find that when they're ill, those diseases have tendency to flare up. Very common. Once the disease is fixed, your symptoms will calm down. Occasionally, you may need to take a little bit more medication during that time period if your symptoms are bothersome. But no, it's very, very common. Actually, even sometimes coming to clinic, if you get anxious, symptoms will often get a little bit worse at that point. And as to the question of being too cautious, that's a difficult question. And I kind of agree with what Dr. Brown has been saying too, is, you know, you have to take care of yourself with COVID, but also this isn't going anywhere anytime soon. So you have to figure out how can I still live my life and do things I enjoy, but not potentially putting myself at risk. And I don't know the answer. I think maybe putting that towards my worry time that Dr. Brown had mentioned, I think I might have to use that.
Those are some great points. I like that. The next question is, when I'm having new symptoms, it's hard to know if it's related to my Parkinson's or not. Should I call my movement specialist, or should I give my primary care doctor a call first?
It's a good question. And it's a tough thing to answer. You know, in general, we think of most Parkinson's symptoms being responsive to dopamine. And just like Nurse Afrow had mentioned, I think it's helpful to fill out a chart before you come in to kind of keep track of when these symptoms occur, because potentially it's related to medication. Is it a certain circumstance that these symptoms come out? Oftentimes, I think the disease is blamed for causing a lot of things. And the problem is I can't prove or disprove that's the case. I think if it's a symptom that's bothering you enough, probably reaching out to both, actually, I think would be helpful. And kind of coming up with a thought about what you want to pursue based off the advice that you're giving. But it's hard, you know, Parkinson's disease isn't the same disease for every patient. So it does become very difficult to figure out what's related to Parkinson's, what's related to something else. So ask, so don't hesitate to reach out.
Well, we'll continue to direct all the hard questions to you, Dr. Phibbs. So the next question is, are apathy and fatigue connected? My husband doesn't want to do much, but it seems a combination of low energy and less interest. How much do I push? Any advice on that?
Yeah, I get that a lot. And truly, it's actually two separate things, but it's really hard to tease them apart. You know, apathy is just and fatigue is more, I think, a physical symptom where patients complain of, I just don't have the energy. I physically feel like I can't do it. But they are very closely linked, like I had said in my talk. And I don't know what pushing is too much. I have 2 teenagers and also run through that issue about how much I push them to do things. I think it's using other things to motivate them to do and to be active. That's where sometimes we use physical therapy, is that way you have somebody else that can come in and motivate your spouse. But I think it's hard. Sometimes, you know, signing up for a gym membership, probably not now, but, you know, personal trainers and stuff like that, because that way it's not always you being, quote, the bad person. Motivating, you know, friends and family also to help out to try and get people motivated. It's hard. And I think talking with the physician too about, you know, what other factors may be kind of contributing, I think is important, but it changes from day to day and situation to situation about how hard to push.
Thank you. The next question is, we're told that COVID may get worse this winter. Any suggestions for how to deal? We know that we need to be moving more. Any suggestions for how to compensate that and deal with the holidays?
So there are certain questions I don't know the answer to either. Actually, Jessica Stroh and I often ponder these questions because I don't know what I'm going to do over the holidays either. And I certainly know within the Nashville area, things are getting worse currently. I think one of the things to rely on is your local regulations and governmental regulations and recommendations, and also following what the CDC is saying. You know, now is probably not the year to have a large group gathering. And some of it is for me, is the guilt is, if I get somebody else sick, my parents live here in town. And if I was the one that would be the transmitter, I would be devastated. But it's hard. This isolation has been going on for 9 months now with kind of no end in sight. Doing things like we are right now, reaching out electronically, can actually be quite fun. You can even play games on Zoom, categories. You can even try, other things. And I think that's another way to reach out with the understanding that, maybe we can't be in person. But the other thing is keeping in mind in your safety. We are strong supporters of masking. It can be uncomfortable if the idea is keeping you safe, and that's very important to do.
Thank you. The last question for you is, what about supplements for energy or for Parkinson's in general?
So supplements, just like Dr. Brown had mentioned, it's tough. Currently, there's no supplement that has been shown to be beneficial for Parkinson's patients. And also, as she said, supplements are not regulated, so you actually don't know truly what you're getting in each of these supplements. The supplements that were mentioned in that question, like CoQ10 and creatine, were actually studied formally in Parkinson's disease, and it was a placebo-controlled trial, and were shown to be not beneficial. I think things that can really make a difference is good sleep, good mood, and self-care, and exercise can help with that too. And sometimes it's chipping away at all the above, but there's no supplement. Unfortunately, I don't have a pill for getting you more perky.
Darn. So that was the last of the questions for Dr. Phibbs. For now, we'll be getting back to everyone. So we're going to move on to Dr. Davis. We'll get Dr. Davis to unmute himself. And he did the talk on updates in treatment and research. And our first question is, where in clinical trials currently is gene therapy for Parkinson's disease?
So the only current gene therapy in Parkinson's disease that was done in the US was insertion of a gene, amino acid decarboxylase, which is the gene that converts levodopa to dopamine. It was done in an attempt to increase dopamine secretion in the brain. It is still ongoing. So although I believe it has reached enrollment, so all of the patients are enrolled, but we are still following it. It has interestingly been used successfully in, there is a very rare disorder in infancy and young children where you're born with a deficit of the amino acid decarboxylase gene, and it's been used in compassionate use in that group and has shown some response in that group.
Thank you. The next question is, I'm interested in trials. How do I find out about them, especially ones at Vanderbilt?
So there are several mechanisms you can get on Kelly Arney's mail list is one. All of the clinical trials that are being done in the United States that are approved are listed in clinicaltrials.gov. And so if you do a clinicaltrials.gov search for Parkinson's and Vanderbilt, you will see the listing of trials that we are currently doing. And then, if you are followed at Vanderbilt, the practitioners that you see should know about the trials. And so those are the three basic mechanisms.
Thank you. In consideration of trying to do a better job of tracking symptom variability, I am wondering what is recommended, what are recommended methods or best practices?
So, Stephen touched on this a bit, and there's several ways to do it. The classic way was kind of symptom diary where every hour of the waking day, for a single day, you shouldn't do it every day, but for a single day or for 2 or 3 representative days, you would decide whether you were off, meaning under medicated, whether you were on, meaning medicated without disabling dyskinesias, or on with disabling dyskinesias. So it's a little bit of a Goldilocks kind of thing where you're either under medicated, you're optimally medicated, or you're over medicated. And then on that same diary, you would note where you took your medication doses. So what you're trying to discover is, like Stephen mentioned, are there patterns? Are there, do you routinely get under medicated after you eat supper? Are you routinely, prolongedly under medicated, in the morning when you wake up? So it's that kind of pattern. There are an increasing number of phone apps and electronic devices that monitor minute to minute, symptomatology. Those are generally used for formal clinical trials and, run the risk of giving you so much data you don't know how to interpret it. I guess if you're trying to, mark yourself, is your finger tapping speed, less now than it was a year ago, you could do something like that. I find the electronic monitors, their best use as a stimulus to exercise, something like the classic activity monitor, step counter, where you're monitoring your daily activity and essentially competing with yourself, or a Zoom group where you're trying to beat, last week's activity level.
I think that really answers the next question about a specific app. So we'll move on to the next question is, my primary care doctor cited some new research on Parkinson's beginning in the gut. And recommended a probiotic. Is there good evidence for this, and could a probiotic help?
So there is some evidence that Lewy body formation in some patients might start in the gut. Whether or not that could be delayed by the use of probiotics is not known. That goes along with the clinical observation that otherwise unexplained constipation occurs in Parkinson's patients often before the motor symptoms occur, and that might be due to Lewy body disease of the gut. Probiotics are probably most helpful as a treatment for constipation and irregularity. They're not going to hurt or interfere with your medication in any way. They might even improve your response to levodopa if they improve your constipation. But there haven't been any formal studies suggesting that use of probiotics slow progression of disease or anything like that.
Thanks. The next question, I found the exercise study with Rocksteady boxing interesting, but boxing is not my sport. As a former runner and now enthusiastic walker, are there studies on walking and Parkinson's disease?
So the study in boxing that Vanderbilt is doing chose boxing not because there's anything magical about boxing, but because it was just a well-documented, standardized exercise protocol that people could do, and it's well-defined. Boxing, I think, is popular because it's done in groups, and so it's kind of a support group activity, and it emphasizes large, rapid movements in all the limbs, and so we think that is good. But aerobic exercise of any kind, particularly maybe high intensity interval training, there's increasing evidence. So if you enjoy walking and don't box, I would not at all feel guilty, number one. I don't know of any formal studies right now of walking, but there's also no evidence whatsoever that boxing is better than walking. So we're glad you're walking and keep walking.
Yes, we're glad. The next one and final one is, you mentioned a model for increasing social interaction initiated by local church groups. Can you give us more information? That was something you mentioned in your talk.
Oh, so I probably should have elaborated on that. It's not so much that the church groups initiated the model, it's just, one of the benefits of church groups in general is socialization. I mean, and that's one of the, that's one of the reasons, that people, benefit from church groups. And so I was just using that as, the fact that church groups go out of their way to socialize. They have potluck dinners, they have, groups that are interested in, this aspect of the religion, this aspect of the religion, so I think they recognize the importance of socialization and do it very well. So that was all I was talking about.
That is the end of the prepared question. Amanda and Jessica have been working on the chats, so I'm going to let them take over and ask questions.
Hi, good morning, everybody. Again, thank you to Kelly. Thank you to all of the panelists for the answers so far on the questions that were received prior to joining. As Kelly mentioned, we are still taking questions via the Q&A box at the bottom of your screen. So thank you to those of you who have already used that. I'm welcoming Jessica Stroh, as you guys probably well know, from our Vanderbilt Center of Excellence team, who will be facilitating some additional questions that we've received and sending them to the right panelists to be answered. But please continue to submit your Q&A. We will get to as many as possible before our noon end time. So Jessica, handing it over to you.
Hello, everyone. Thank you so much for joining us today. We're so glad that we could do our own virtual version of our annual Parkinson'S Symposium, and we're just thrilled that you could join us. Dr. Brown, this first question, Dr. Amy Brown, this first question is for you. Is there a specific test for Lewy body dementia or Lewy body disease?
No. Unfortunately, it is. It has to be an autopsy diagnosis for Lewy body dementia or Lewy body disease. So it's basically, if we're thinking of Lewy body disease, we're looking for certain signs or certain symptoms that are different from Parkinson's disease. There was a time that, both Parkinson's and Lewy body dementia have the formation of Lewy bodies. And there was a time where these were kind of thought to be similar. Parkinson's, like Lewy body dementia, was part of Parkinson's disease. Since then, we've really separated, and actually we're realizing more that Lewy body dementia is like the second most common neurodegenerative disease, right under Alzheimer's disease. And to really think of Lewy body dementia, you are thinking about, early dementia, like pretty much within the same year that you start having Parkinson's symptoms, as well as like delirium symptoms. But unfortunately, often we still think maybe we will try Sinemet and try treating this like Parkinson's disease, because both Lewy body dementia and Parkinson's disease can't officially really be truly diagnosed. I mean, it's a clinical diagnosis for both of them, but to really make the definitive would be an autopsy. So we have nothing yet.
Thank you. Dr. Davis, this next question is for you. It's about a medication called Nelotinib and inquiring if it would be helpful for Parkinson's disease, and if so, why or why not?
So Nelotinib is a drug that is FDA approved to treat lymphoma. It is thought as one of its kind of side actions to increase autophagy, which is the mechanism by which your body rids itself of toxic proteins. And for that reason, was a potential agent for a number of neurodegenerative diseases. There have recently been 2 studies of Nelotinib, and unfortunately they had a little bit of conflicting results, one suggesting that it was helpful and the other one showing no effect. So it is a very expensive therapy. It, as one of its side effects, immunosuppresses people. So it would not be a good drug to try in the middle of a pandemic. But I think it is too early to tell whether or not Nelotinib is going to be a helpful drug for Parkinson's disease. So I would hold off for now.
Thank you, Dr. Davis. Dr. Kelly Brown, this next question is for you. The patient is saying that they're having more vivid dreams than ever before. Do you think this is likely due to how long they've had Parkinson's disease? They were diagnosed 16 years ago.
It's hard to know what they mean by vivid dreams. Do they mean that they're just having vivid images, or are they actually acting out their dreams? Some patients tell me they're having vivid dreams, and when I talk to them, they say they're actually dreaming that they're in a fight and they start punching their bed partner, or they dream they're kicking something and they kick their bed partner. And those are kind of 2 separate issues. The vivid dreams could be medication side effect. There are some medications, including even blood pressure medicines, that can contribute to vivid dreams. Sometimes when you wake up more during your REM sleep, you'll remember your dreams. So you'll feel like you're having more vivid dreams, but if you sleep straight through your REM sleep, you won't remember the dreams. Things that make you wake up frequently in REM sleep especially would include sleep apnea, which is much worse in REM sleep. So it might be worth considering a sleep test, particularly if you're having any other symptoms of sleep apnea, including snoring or disrupted sleep or feeling tired in the day. If you are acting out your dreams, that may be something called REM behavioral disorder, which is associated with Parkinson's disease. And we do treat that by usually the medication melatonin. If there's underlying sleep apnea, treating that can help the behaviors. And sometimes we give some more stronger sedative type medication if needed. I will also add one thing. If you're acting out of your dreams, you should be very careful, not just to kind of protect your bed partner, but don't keep anything sharp near your bed, no glass tables or glass lamps, and particularly be very careful with weapons. You don't want a weapon in your room, especially a loaded weapon, if you're going to be acting out your dreams.
Thank you. Stephen, this next question is for you. We have a question about how mood changes in caregivers due to what's going on with the patients. So do you have any suggestions for, caregiver fatigue, caregiver role strain?
Yeah, we do. We certainly do see that a lot, where as patients progress and as things get harder, the caregiver feels that burden for sure, whether it's issues with daily activities or issues with transportation, whatever it may be. The good thing is there are a lot of resources out there, and we've mentioned support groups for sure. There are even support groups for caregivers, which we do certainly recommend. That is a valuable resource because you're coming at this from a different perspective. You're not the one with the actual symptoms, but you are experiencing them basically as closely as you can. We also always encourage caregivers to reach out to us. I always have a lot of caregivers message me directly and kind of discuss their concerns outside of the visit. So that is also helpful for them to be able to ask their questions and to be able to really talk about their concerns without the patient sitting right next to them. So again, as I mentioned earlier, we're all a team in this. If the caregiver is struggling, that's just as concerning to me as the patient struggling. So, don't be afraid to speak up.
Thank you, Stephen. Dr. Phibbs, this next question is for you. My husband has issues with food getting stuck sometimes during meals. Is this his PD?
Parkinson's disease certainly can cause difficulties with swallowing. We can see it both with solids, but also liquids. Some patients also complain of difficulties with food that's crumbly, things like cornbread and stuff like that. It certainly can be. If we're seeing issues like that, the concern is actually development of a pneumonia where the food goes down into the lungs instead of into the stomach. Speech therapy is a good place to start. They also work with swallowing and can work with like tips and hints about how to swallow, tucking your chin, stuff like that. If there's enough concern, they often will recommend what's called a video fluoroscopy swallow test to actually see what happens with the swallowing mechanism. It has also been my experience that, again, like I mentioned earlier, we're often blamed, but patients can have other issues. So it's important that we do get it looked at and to make sure that there's nothing else going on.
Thank you, Dr. Phibbs. Dr. Davis, we actually have 2 questions for you. The first one is, what happened to your bow tie? Is it missing? And do we need to send out a search party?
So the bow tie is one of many of the things that went away with the COVID restrictions. So I rounded earlier this morning in the hospital, and the current guidelines say that you're not supposed to wear anything that can't be laundered daily. And so this question made me think, this is the longest I've gone without wearing a bow tie in the past 40 years. So,
well, now a slightly more serious question for you, Dr. Davis. There are several trials ongoing in patients with Parkinson's disease with agonists of GLP-1R, including exenatide and others. Do you think the rationale for the neuroprotective effects of this mechanism holds promise?
So those are agonists of the glucagon receptor, and they're typically used those drugs are typically used to treat diabetes. There is some evidence that stimulation of that receptor in neurons decreases inflammation, increases autophagy, and increases removal of abnormal proteins in general. And so there is some rationale for their use. I don't know how good it is. Oral agents that stimulate that receptor have been tried in Parkinson's disease and failed. Probably the most positive study was done in England. That was a small group of patients and studied patients in mid-disease, which is unusual for a drug that's thought to slow progression. Usually the progression studies are done in patients who are very early in disease. And what was seen in these mid-stage disease patients was improvement in their symptoms. So it's unclear whether the drug was actually providing any neuroprotection or whether it was simply providing a symptomatic response, and whether that symptomatic response was a placebo response is unknown. So I think, again, I think it's a little early. I think there is some rationale for it. It's tempting to use drugs that are clinically available for uses that are not approved, but these drugs have side effects, and I think it's probably better waiting until the studies are done to try them.
Thank you, Dr. Davis. Dr. Phibbs, this question is for you. When having surgery, they're asking at Vanderbilt, but really at any hospital, what do I need to make sure that my surgical team, including my surgeon and anesthesiologist, know about Parkinson's disease?
Actually, Kelly Arney has a hospital packet that's available through the Parkinson's Foundation that I think is a great tool to use. I think, unfortunately, patients often end up being the educator to their physicians about their disease because everybody's disease treatment is so personalized. So I think if you can, discussing with your team ahead of time about the importance of being on time with your medications, mentioning that if you don't get your medications on time, that you have difficulties with mobility, increased falls, that kind of thing, because it really engages them to understand that to give you the best outcome possible, getting your medicines on time is very important. I will tell you, being in the hospital as a Parkinson's patient is very challenging. You know, the nurse to patient ratio is unfortunately not always in the patient's favor, especially if you have a difficult medication regimen, because they just don't have enough time to get you the medications on time. And there's a kind of plus minus window of time that they have to give you the medication with it still being, quote, on time. So sometimes medication doses can actually be right on top of each other. So talking with the nursing staff too, and even potentially asking your surgical team ahead of time, hey, can I take my own medication? That way there's an expectation of, I know when I need it, that way I can be sure to get it on time. As far as Parkinson's disease itself, not necessarily. I think the anesthesiology before you would undergo surgery would have an extensive discussion with you about, you know, concerns for anesthesia and such. But there sometimes are medications that patients take that there might be an interaction, but they will talk with you about your medications ahead of time. But the main thing is talking with your surgeon, because they'll be kind of your boss while you're in the hospital, about the importance of medication timing.
Thank you, Dr. Phibbs. Dr. Kelly Brown, which medications don't mix well with driving? I know someone who was arrested and charged with DUI because she was taking clonazepam for her Parkinson's disease.
Okay, I assume you're asking about sleep medications in particular. Any sedating medication, we would worry if the effects are still in your body and you're driving. So we usually recommend that you leave adequate time for sleep if you're taking a medication before sleep, which would be usually at least 8 hours or more. It depends on the half-life of the medication, but clonazepam does have a very long half-life. So even if you take it at night, it might have effects the next day. If you're taking it for Parkinson's and you do have to take it in the daytime, that's something to talk about with your Parkinson's doctor. I will say that other sleep medications, even that have a shorter half-life, like things like Ambien or other sleep medications, can have a hangover effect the following day. And that's been well documented. So women, we don't recommend take more than 5 milligrams of a drug like Ambien, men 10. But any of those medications can have a next day hangover effect. So you always want to take the medication on a day when you don't have to drive the next day, and be very careful that it's not going to be affecting you the next day when you're driving. In general, we don't recommend, in sleep medicine anyway, we don't recommend any controlled substances for sleep. We try to avoid all of the controlled substances, and that would include benzodiazepines like Klonopin, and then the sleep meds you see ads for on TV like Lunesta and Ambien and those types of things. When we do use sleep medication, we try to use melatonin or some of the antidepressants or a medicine called gabapentin or Neurontin, but we really try to avoid controlled substances for that reason.
Thank you, Dr. Brown. Dr. Amy Brown. All of my toes are numb and tingly all of the time, and this numbness can be very painful, especially after heavy exercise or a long day on my feet. I can feel a light touch on each toe, and I've been tested for neuropathy and diabetes, and I reportedly don't have either. How common is non-diabetic numbness in the extremities, and is it a symptom of Parkinson's? Additionally, is there anything that can be done about it?
So it can be a symptom of Parkinson's. It's not relatively common, but some people do get these neuropathic pains. It can be more like genetic, familial, meaning, you know, you got it from your Parkinson's symptoms from your parents. You can have more of a neuropathy concern. It also can be an off side effect, meaning that your levodopa or Sinemet is not as effective and you might need a little bit more, particularly if it's occurring following, you know, rough exercise or just being more active than normal. And so sometimes what we do is we try to increase your Sinemet dose or take a little extra as needed when those symptoms do occur. If it's more at nighttime, we would consider like restless leg symptoms and evaluate for that. And then there are medications that we can consider trying. Some people do start with like capsaicin or creams or lotions and stuff, but we could consider, higher medications depending on the symptoms. But usually we try to evaluate kind of when it's occurring and why, and treat it from there.
Thank you, Dr. Brown. Stephen, this next question is for you. There are a lot of issues with balance and falling, as well as muscular deconditioning. I've recently seen an exoskeletal assistant, much like a gait belt for the body. Are you familiar with this, or do you have other recommendations about strengthening and mobility?
I mean, the tried and true method is going to be like exercise, physical therapy, things that we know work, things that are going to be safe. Something like that, while it does sound cool and helpful, I would assume also is probably very expensive. And to my knowledge, hasn't been extensively tested for Parkinson's patients. So really what we want to kind of work on is what I like to say, the old-fashioned stuff, is practice what you are struggling with physically, versus relying on something like that, because we don't necessarily know how well it's going to work down the road. But the tried and true method, physical therapy, exercise, and just practicing. And what I tell a lot of my patients is, you know what, when you have Parkinson's and you are a little bit older, it's kind of just like when you're a kid again and you're learning how to walk. Kids just don't pop up and start walking on day one. You have to learn, and you have to struggle, and you have to practice, and you have to fail, and you have to fall. And it's kind of that same thing in Parkinson's. You have to learn to adapt, and you have to learn to kind of re-walk and learn what your body needs. So kind of do it the old-fashioned way is what I recommend.
Perfect. Thank you, Stephen. To all of our listeners, watchers, please be sure and check in the chat. Annie from the Parkinson's Foundation has provided links to the free medical alert card for your wallet, so that if you do have not necessarily benzodiazepine use, but if you have difficulty with your Parkinson's disease that impairs your mobility, you may find it helpful to have one of those cards with you that you can easily get out along with your wallet should something occur, and the card can speak for you and let the emergency services personnel know that you are not impaired, you just have a medical condition. Additionally, Annie was kind enough to share the Aware and Care Kit link, which actually allows you to order one and have it delivered to your home. If you have difficulty with that, you can reach out to Kelly. She can also help you get one if ordering things online is not your favorite thing to do. I don't see any other questions in the chat. Amanda, any that we're missing?
Hey, Jessica, we do have a couple more questions. One that I know is often popular. Is there a specific diet that you would recommend that, or research has concluded, is better than another for Parkinson's?
I can answer that one. So the common diet question, there are two things with diet. One is that levodopa is an amino acid and competes with other amino acids for absorption. So levodopa in some people is more effective if it's taken, on an empty stomach before or after a meal rather than with a meal. There are many people where that has no effect. So if you notice a protein sensitivity where your levodopa does not work as well, if it's taken with a protein meal, you might want to decrease the protein in your diet. Other than that, there's not a specific diet. There is some increased push that the Mediterranean diet, which puts you at lower risk of heart disease and stroke, might decrease risk of cognitive deficits in Parkinson's disease. Just because it decreases risk of cognitive deficits in everyone. And so the Mediterranean diet, which would just generally be a good health diet, has been advocated by some. So other than that, no specific diet.
Thanks, Dr. Davis. And then we have one final question, and feel free to jump in on the panelist who feels best to handle, but is there any information you can give about using the Vanderbilt specialty pharmacy for some of the treatments available?
So I can answer that one also. The Vanderbilt specialty pharmacy has on its the ability to dispense some of the specialty medications that are also available through other specialty pharmacies. If you are interested in utilizing those, you can, and you're seen at Vanderbilt, you can talk to your practitioner about it. They have been very helpful, I think, in getting patients, navigating them through the paperwork that's often required for specialty drugs. And so I think, you know, that's where it's had their big advantage. So yes, certainly if you're on a medication that is dispensed by a specialty pharmacy, you can ask your practitioner if it's available through the Vanderbilt Specialty Pharmacy. I want to thank Dr. Kelly Brown for joining us. We hardly ever get a sleep specialist, and so I really appreciate your time, Dr. Brown. That's one less thing I'll have to do during my worry time now, is worry about that. So thank you, thank you. I think your YouTube video had the most hits of any of ours. So you'll probably be getting some like YouTube income.
Okay. There's we have a lot of great sleep providers at our sleep center, and if anyone is having sleep issues, they can talk with your team or their primary care and come see any one of us. We have several locations, and we have a lot of really great providers, so thank you.
Well, a very special thank you to all the panelists. Before I turn it back over to Kelly for just a quick close, I do want to make sure everybody knows that we have recorded today's session and it will be available very soon. We certainly will be sharing the link to this on the Parkinson's Foundation Tennessee, Kentucky chapter Facebook page and on our website. And of course, Kelly and team will have it available through her email distribution list. And of course, you can reach out to either of us to make sure that you have access to this link as well. So Kelly, turn it over to you for any final remarks.
Well, just another thanks. It takes a team to make this happen. And thank you, Jessica, for supporting the process, and all the doctors for getting their talks uploaded on the website early. Usually we don't make the talks available to the day of. But I just want to let everyone know that although this is a big event, and I know we're all missing the big breakfast that we usually come out to get, we also are having meetings throughout the year, and we're working with the Parkinson Foundation to do an event next month on in-home therapies. So if you're not receiving emails from me or the Parkinson Foundation, email us and we can get you added so that you're aware of these programs. I know we're all getting a little Zoom fatigue, but there are a lot of good options, and we still are having some small group for caregivers and for patients, support groups, if that sounds of interest. Or if you just prefer to talk one-on-one, reach out to us, and we can do it that way too. So we're all learning during this process, and we're trying to meet the needs that way. So if you have ideas for that, we'd love to hear them and continue to try to fit our programming for your needs. So it was so good to get together this morning, and it was a lot less stressful having this big team get it all together. And thank you for the Parkinson Foundation doing it in this format. I think it worked very well. But thanks everybody, and we'll look forward to hopefully not another virtual symposium, but that we'll be together live next year.
Everybody have a great day.